Picture this. You're sitting in the glow of your laptop at like, what, 2 a.m.?
Yeah, and you're just in chronic, agonizing physical pain.
Exactly. I mean, you've been to multiple doctors, you are rigorously applying the prescription creams they gave you, but you're still suffering, so you turn to the internet.
As we all do.
Right, as we all do. And within seconds, you are absolutely bombarded by these glossy clinic websites and pop-up ads, all promising a miracle cure.
Oh, the miracle cure marketing is everywhere.
It really is. They're pitching this quick, drug-free injection that will, not only stop your pain, but completely rejuvenate your tissue. And it sounds way too good to be true, but when you are desperate for relief, that marketing is incredibly seductive.
It's hard to ignore when you're in that much pain.
For sure. So today we are taking a massive stack of sources. I mean, everything from cosmetic surgery brochures and patient advocacy files to double-blind clinical trials, and we are stripping away that glossy marketing to find the cold, hard science underneath.
Because we are looking at a medical landscape where the marketing of regenerative therapies is moving at just absolute light speed, while the peer-reviewed science is still, lacing up its boots.
Lacing up its boots, yeah.
And the specific battleground we're looking at today is the application of platelet-rich plasma therapy and its trademarked spin-off, the O-shot, for a condition known as lichen sclerosus.
So let's unpack this, because before we can dive into the centrifuges and the stem cells and all that, we really need to understand the beast we're actually fighting here.
We do.
Because scanning through these patient files from the Lichen Sclerosus Support Network, or LSSN, the reality of this condition is just brutal.
It is entirely brutal. And, you can't evaluate a proposed cure without understanding the actual mechanism of the disease.
Right.
So lichen sclerosus, which is usually abbreviated as LS, is a chronic autoimmune inflammatory skin condition. And it primarily targets the anogenital region. So for women, we're talking about the vulva, the perineum, and the perineal area. And for men, it primarily affects the foreskin and the glands of the penis.
And the symptom descriptions in these LSSN advocacy articles, they really don't hold back. They describe this intense, just relentless itching that completely disrupts sleep and daily life.
It's maddening for the patients.
I can't even imagine. And the skin itself undergoes these visible changes, right? Turning a very distinct, pale, kind of ivory white color.
Yeah, that color change is actually a hallmark of the inflammation physically altering the skin barrier.
Wow.
The tissue becomes incredibly fragile. Patients experience tearing and microscopic fissures just from everyday movements. Literally just from walking or wearing fitted clothing.
It's from clothes.
Yes. But the true danger of LS lies in its progression. In severe, untreated cases, that chronic inflammation causes the tissues to scar and physically fuse together.
The architectural changes described in the medical literature are terrifying. In women, the labia minora can literally reabsorb or disappear entirely.
Yeah, it just flattens out.
And the clitoral hood can fuse, completely burying the clitoris beneath thick scar tissue.
Which, as you can imagine, causes unimaginable pain during intimacy.
Right.
And on top of the immediate physical trauma, untreated lichen sclerosus carries a systemic, long-term threat. There is an estimated 10% risk of developing into squamous cell carcinoma, which is a highly aggressive type of skin cancer.
So that puts this entirely out of the realm of like a minor dermatological annoyance. This is a severe progressive disease.
Absolutely.
Now, looking at our academic sources, the medical community does have a recognized gold standard for treating this, right? The heavy hitters are these ultra-potent topical corticosteroids, specifically a medication called clobetasol, or alternatively, calcineurin inhibitors.
That's right.
But here is where I really need to step into the shoes of the patient awake at 2 a.m. If we have a medical gold standard that every dermatologist agrees on, why are people seeking out experimental injections?
That's a great question.
Is it a situation where the treatment is almost as bad as the disease? Are we basically using a sledgehammer to push in a thumbtack here?
Well, the sledgehammer analogy actually falls a bit short because the disease itself is a wrecking ball.
Okay, fair.
Clobetasol is remarkably effective at its primary job, which is stopping the autoimmune inflammation. When researchers look at the biopsies of patients who use these potent steroids correctly, the inflammatory markers just plummet.
Oh, wow.
Yeah, the medication halts the progression of the fusing and drops that 10% cancer risk right back down to the baseline of the general population.
That sounds like a massive success story.
It is, medically speaking. But there's a massive catch. First, achieving that success requires lifelong, rigorous compliance.
Lifelong.
Right, a patient doesn't just apply the cream until the itching stops. They have to use a maintenance dose forever to keep their immune system suppressed in that specific local area.
That sounds exhausting.
And second, long-term application of ultrapotent steroids carries its own risks. It can sometimes cause the healthy surrounding skin to thin out and lose its structural integrity, which is a process called atrophy.
Oh, right. And according to the LSSN patient forums, sometimes the medication just stops working entirely. Wait, the medical term in the literature for this is tachyphylaxis, meaning the body basically builds up a tolerance and the steroid loses its efficacy over time.
That is the exact mechanism, yeah. For a significant subset of patients, tachyphylaxis kicks in, or the steroids simply aren't enough to relieve the residual symptoms.
So the steroids act like a fire hose. They put out the active fire, but they don't rebuild the house.
Exactly.
The microscopic inflammation might be suppressed, but the patient is still left living in the wreckage, dealing with fragile, scarred, functionally compromised tissue that makes daily life and intimacy incredibly painful.
And that chasm between, the disease is clinically managed under a microscope and the patient actually feels normal again, that is exactly the vulnerability that regenerative medicine clinics are targeting.
Enter PRP and the O-shot. I have to admit, reading through the marketing materials for these clinics, the enthusiasm practically jumps off the page.
They are very enthusiastic.
So let's define the tech. PRP stands for platelet-rich plasma, and the O-shot, or orgasm shot, is a highly specific branded spin-off of this technology created by a physician named Charles Runels.
Right, and to understand the appeal, we really have to look at the actual cellular biology of how this therapy operates.
Yeah.
It relies on the patient's own blood, making it an autologous treatment.
So they use your own stuff.
Exactly. A patient walks into a clinic and the practitioner draws a standard vial of blood from their arm.
And the sources mention they take that vial and place it into an FDA-approved centrifuge, specifically naming machines like the Magellan or self-vial systems.
Yeah, the centrifuge is really where the magic happens. It spins the blood vial at an incredibly high RPM.
Okay.
And because blood is comprised of elements with different densities like the liquid plasma, the red and white blood cells, and the platelets, that extreme centrifugal force separates them into distinct layers.
So it's isolating the parts.
Exactly. The goal is to isolate the specific golden layer of plasma that contains a massive concentration of platelets.
The doctor then extracts that concentrated platelet-rich plasma, numbs the patient's vulvar and clitoral region, and injects it directly back into the tissue.
Right.
And the O-shot protocol specifically targets an area they refer to as the O-spot, which is located between the urethra and the anterior vaginal wall. But let's pause on the biology for a second.
Mhm.
Why are we isolating platelets? We usually just associate them with blood clots, right?
They are the body's first responders for clotting, yes.
Yeah.
But their secondary function is actually far more vital for regenerative medicine.
Really?
Yeah, platelets contain these tiny specialized granules packed with growth factors and cytokines. These are essentially signaling proteins.
So if we use an analogy, it's less like sending in the bricks and mortar to fix the damaged house and more like sending in the cellular foreman with megaphones.
I like that.
Those cytokines are basically shouting at your local dormant stem cells to wake up, start multiplying, and begin rebuilding the infrastructure.
That captures the mechanism beautifully. You are taking the body's own natural healing signals, artificially concentrating them by a factor of 5 to 10, and injecting them precisely where the tissue is compromised.
That's wild.
Right. Those growth factors command local fibroblasts to produce fresh collagen, and they trigger neovascularization.
Neovascularization, meaning the literal construction of new blood vessels in the damaged area.
Yes. And new blood vessels mean increased blood flow, which brings oxygen and nutrients to tissues that have been completely suffocated by that rigid scar tissue.
Okay, before we go further, we really need to clarify a distinction that comes up constantly in our stack of sources. Because PRP and the O-shot are often used interchangeably in these clinic ads, but they aren't the same thing.
No, they aren't. If we connect this to the broader medical landscape, PRP is the foundational biological therapy. It is not new. It has been utilized for decades across multiple disciplines. Orthopedic surgeons use PRP to accelerate the healing of torn tendons. Oral surgeons use it for bone grafts. Dermatologists use it for severe wound healing.
So it's everywhere.
Exactly.
Yeah.
The underlying science of platelet-rich plasma is widely researched and well-established.
Whereas the O-shot is a trademark.
Yes, the O-shot is a proprietary trademarked protocol. Dr. Runels created a specific standardized method of preparing that PRP and injecting it into highly specific anatomical coordinates in the female genitalia.
Okay.
It was originally designed and heavily marketed to address female sexual dysfunction and urinary incontinence, promising to, increase natural lubrication, heighten arousal, and intensify orgasms.
But the clinical applications have clearly expanded because now it is being aggressively advertised as a frontline treatment for lichen sclerosus.
It really is.
And the claims on these cosmetic and urology websites, places like Elite Aesthetics, Tower Urology, and Renaissance MD, are just staggering. Here's where it gets really interesting. Some of these industry-backed studies, prominently displayed on their sites, claim success rates hovering between 75 and 94%.
And the list of physiological benefits they promise to patients suffering from LS is incredibly comprehensive.
They claim the injections activate, quote, omnipotent stem cells to regenerate the vulvar tissue. They promise a return to younger, smoother skin, a tighter vaginal canal, and most importantly for this specific patient demographic, massive relief from dyspareunia.
Right, which is the medical term for the severely painful intercourse caused by the disease's scarring.
When you view those promises through the lens of a patient whose anatomy is literally fusing together, it is entirely understandable why they would immediately pick up the phone to book an appointment.
Especially when you factor in the logistics of the procedure itself. It is marketed as the ultimate biohack.
Yeah, it's drug-free. You aren't putting synthetic pharmaceuticals into your system. You are using your own biological material, meaning the risk of an allergic reaction is like virtually zero. The entire process takes maybe 15 to 30 minutes in a clinic chair, and they boast about zero downtime. Patients are told they can theoretically resume sexual activity that exact same day.
It is positioned as the perfect, frictionless silver bullet.
But that frictionless bullet requires a massive financial sacrifice. I mean, our sources show these clinics are charging anywhere from $1,500 to $4,000 per treatment.
And it's rarely just one treatment.
Right. The protocols often require an initial series of shots, followed by annual maintenance. Yet, despite the glowing testimonials and the really high price tag, when you look at the actual academic reviews, the scientific community is highly skeptical.
The friction between the marketing and the science is severe. The academic systematic reviews in our stack, particularly the comprehensive 2021 review led by Villalpando and colleagues, alongside the Medical Advisory Board of the LSSN, uniformly classify PRP and the OSHOT for LS as experimental.
Experimental, meaning despite the clinic claims of 90% success, the medical establishment does not consider this a proven treatment.
To understand that disconnect, we have to examine what medical science actually accepts as proof. Which brings us to the 2019 study published by Dr. Andrew Goldstein and his team.
This is a big one.
This is arguably the most crucial piece of our source material because it isn't just a survey. It is a randomized, double-blind, placebo-controlled trial. In the hierarchy of scientific evidence, that is the gold standard.
The methodology they use to remove the placebo effect is actually incredibly rigorous. Walk us through how they blinded this study because they went to extreme lengths.
They really did. So they recruited 30 women, all with biopsy-confirmed vulvar lichen sclerosus. They randomized them into two groups. 20 women received the actual concentrated PRP injections.
Okay.
The remaining 10 women served as the control group, receiving a sham treatment, which was an injection of simple, normal saline.
And to ensure that neither the patient's hope nor the doctor's bias influenced the results, they literally physically blacked out the syringes with opaque tape.
No one in the room knew what was inside the needle.
Wait, they taped over the syringes?
Exactly. Total blinding. The practitioner administering the shot didn't know if they were delivering liquid gold platelets or plain salt water, and the patient certainly didn't know.
That completely neutralizes the placebo effect. I mean, if you are paying thousands of dollars for a regenerative therapy, you desperately want to believe it works.
Of course you do.
The tape removes that psychological expectation. But the most critical part of this study wasn't just the blinding, it was how they measured the outcome. They didn't just hand the patients a questionnaire about their pain levels.
Right. They relied on objective cellular data. The researchers took physical biopsies of the affected vulvar tissue before the treatment protocol began. Yeah. Then, after the treatments were concluded, they took secondary biopsies from the exact same areas. Those tissue samples were sent to expert dermatopathologists who were also blinded to the study's parameters.
So the pathologists are just staring through a microscope, counting the actual inflammatory cells, the lymphocytes in the tissue, completely unaware of who got the real shot. Since you mentioned this study is why the treatment is considered experimental, I'm guessing the objective reality under the microscope didn't quite match the glossy brochures.
The results were definitive.
Yeah.
The microscopic analysis showed that PRP was entirely ineffective at reducing the actual autoimmune inflammation caused by lichen sclerosus.
Wow.
The disease was still raging, the inflammatory markers were just as high, and the microscopic destruction was progressing at the exact same rate in the PRP group as it was in the placebo group.
Wow. So at a foundational cellular level, the therapy just failed to stop the disease.
It did.
But this raises an important question, because right next to the Goldstein study in our stat is a 2020 study by a researcher named Tedesco, and that study paints a wildly different reality.
Oh, the Tedesco study is heavily cited by the clinics. It was a larger cohort, 94 patients, encompassing both men and women with LS.
Okay.
And the results of that study showed that a significant majority of patients reported massive, life-altering symptom relief. They documented drastically reduced itching, diminished burning, and a return to pain-free intimacy.
If you are the patient trying to decide what to do with your savings, you are now looking at two entirely conflicting realities. A microscope telling you it absolutely does not work, and 94 people telling you it saved their sex lives.
It's confusing.
Why the massive discrepancy?
The discrepancy lies in the methodology. The Tedesco study lacked a placebo control group, but more importantly, it lacked pre- and post-treatment biopsies. They did not measure the objective cellular inflammation, they only measured the subjective human experience.
I have to jump in here and advocate for the patient, though. Looking at the LSSN comments section, there's a patient named Joanne who writes that she is absolutely thrilled she spent the money on the O-shot because her pain is finally gone.
Which is amazing for her.
Right. If Joanne says she has her life back, who cares if a blinded dermatopathologist found lymphocytes under a microscope?
That exact tension is the multi-million-dollar question in regenerative medicine right now. And if we synthesize these two seemingly contradictory studies, a highly plausible, fascinating biological theory emerges.
Let's hear it.
PRP is not an immune modulator. It is not biologically capable of communicating with your immune system to tell it to stop attacking your own skin.
Right.
That is the objective inflammation the Goldstein biopsies were measuring, and PRP cannot stop it.
However, the growth factors in PRP are incredibly effective at aggressively promoting tissue healing, rebuilding blood vessels, and restoring elasticity to fibrotic tissue.
So it is repairing the collateral damage caused by the fire, even though it doesn't have the tools to actually put the fire out itself.
Exactly. It is treating the physical symptoms and the architectural destruction left in the wake of the disease, rather than the root autoimmune cause of the disease.
So what does this all mean for you, the listener, trying to navigate this? Do you abandon the steroids and book the shot?
The overwhelming consensus from both the Lichen Sclerosus Support Network and the leading dermatological specialists is definitive. The O-shot and PRP should never be utilized as a primary monotherapy.
You cannot throw away your clobetasol cream. Absolutely not. If you abandon the steroids and rely solely on PRP, you might experience a honeymoon period where your tissue feels better, all while the underlying autoimmune disease silently ravages your cells in the background, keeping your risk for squamous cell carcinoma elevated.
That's terrifying.
Instead, the medical consensus suggests viewing PRP strictly as an adjunct therapy.
An add-on to the gold standard.
Yes. Consider a scenario where your topical steroid gets you to 80% relief. The medication successfully halts the inflammation, and your cancer risk drops.
But you're still uncomfortable.
Right. You're still burdened with that fragile, scarred tissue that makes movement and sex painful. In that specific scenario, a regenerative therapy like PRP might be the biological bridge that helps heal the structural damage, bringing your quality of life closer to 100%.
That makes perfect logical sense. You use the heavy machinery of the steroids to stop the wrecking ball, and then you send in the cellular foreman to rebuild the living room.
Precise.
But if PRP is essentially dropping growth factors onto damaged tissue to rebuild it, what happens when the tissue is too severely scarred and fused for those platelets to even penetrate? Because our sources heavily feature clinics escalating to other more aggressive therapies.
They do. When the fibrotic scarring is too dense, clinics pivot to therapies that physically alter the tissue architecture.
Like what?
Well, the most prominent in our sources are fractional CO2 lasers, like the heavily marketed MonaLisa Touch and surgical fat grafting.
How does firing a laser into scarred tissue actually heal it?
The mechanism is counterintuitive. A fractional CO2 laser vaporizes tiny microscopic columns of tissue in the vulvar canal.
Wait, it vaporizes it.
Yes,
Yeah.
by intentionally creating these controlled microwounds, it forces the body into an emergency repair state. It essentially tricks the local fibroblasts into mass-producing fresh elastin and collagen to heal the burns.
Oh, wow.
And this rapid influx of new collagen softens the rigid, fused tissue caused by the LS.
But just like PRP, the academic sources note a stark lack of biopsy-proven evidence that lasers actually reduce the underlying autoimmune inflammation, right? That's just another structural repair tool. Which brings us to the fat grafting, which sounds incredibly intense.
It is a minor surgical procedure, often referred to as lipotransfer or a labial puff. A prominent cosmetic surgeon named Paul Banwell features heavily in the literature discussing this, and its efficacy was recently explored in a study known as the PETALS trial, researched by scientists like Boero.
What is the actual mechanism behind moving body fat to treat an autoimmune disease?
So the surgeon harvests adipose tissue body fat, usually from the patient's abdomen or thigh. They purify it and inject it directly into the fused, scarred vulvar region.
Okay.
The theory hinges on the fact that human adipose tissue is incredibly rich in dormant stem cells.
So it's serving a dual purpose. It acts as a biological filler to physically stretch and break down the rigid fibrotic bands, while simultaneously delivering a massive dose of stem cells to regenerate the tissue.
The structural improvements for patients with severe architectural changes are reportedly profound. But again, the scientific community classifies it as an experimental adjunct, not a cure for the baseline disease.
Now, as we analyze this entire ecosystem of expensive, heavily marketed procedures, the O-shot, the fractional lasers, the stem cell fat grafting, there is a perspective in the LSSN patient files that fundamentally reframes this entire conversation for me.
Yes, the comment from Diego.
It's a comment from a patient named Diego.
Diego's observation highlights a deeply uncomfortable reality about how medical innovation is distributed.
Diego is a man suffering from severe penile lichen sclerosus, and he points out a glaring systemic double standard. Women with LS are constantly targeted by an incredibly robust, well-funded industry of vaginal rejuvenation.
Everywhere you look.
Right. Clinics are eager to take thousands of dollars to provide the O-shot, laser therapy, and fat grafting to restore their aesthetic and sexual function.
Meanwhile, Diego writes that his physical anatomy is being destroyed by the exact same disease, yet he cannot find a single surgeon willing to offer him regenerative therapies.
That's just wild.
When he advocates for reconstructive options like a scrotal skin graft to repair his fused tissue, he is met with blank stares from urologists.
He is in physical agony, pleading for a return to a normal quality of life. But the options simply do not exist for him in the same accessible, heavily marketed way. Why is the landscape so uneven?
If we view this purely through the lens of market forces, it reveals that access to medical innovation is undeniably shaped by profit margins and societal aesthetics.
There is a massive, highly lucrative market for female cosmetic rejuvenation. So private clinics invest heavily in the technology, the laser machines, and the marketing budgets.
Exactly.
But for men with penile LS, that identical cosmetic profit motive just doesn't exist. So the clinical reconstructive options severely lag behind.
It is a stark reminder that medical innovation isn't solely driven by a pure desire to heal. It is often driven by what sells to the largest demographic, and that market reality leaves patients like Diego falling completely through the cracks of the healthcare system.
Bringing this massive stack of sources together, what have we actually uncovered? PRP, the O-shot, and these alternative regenerative therapies are undeniably fascinating tools.
They really are.
By utilizing the body's own growth factors and stem cells to signal healing and rebuild blood vessels, they offer many patients genuine, life-altering relief from the physical devastation of lichen sclerosus.
But the critical takeaway for anyone navigating this space is that they are not a cure. The objective, double-blind biopsy data proves they do not stop the underlying autoimmune inflammation.
Right.
Therefore, they cannot safely replace the gold standard medical treatments like topical steroids that are absolutely required to prevent the disease from progressing into irreversible fusing or cancer.
They are a biological bridge, not the final destination.
A bridge that requires careful navigation alongside a specialist.
Which leaves us with a final thought to ponder. We've established that therapies like PRP and fat grafting rely entirely on harvesting your own body's cells, your plasma, your platelets, your adipose stem cells to heal you.
Yes.
But if you are suffering from lichen sclerosus, you have a systemic autoimmune disease. Your immune system is fundamentally miscalibrated.
It is.
So what happens when we rely on a compromised system to cure itself? Are we extracting healing factors, or are we just spinning down and re-injecting the exact cellular dysfunction back into the source? It's a biological loop that the next generation of medical researchers is going to have to untangle.
It is a complex frontier, and the science is still playing catch-up.
Thank you for joining us on this deep dive into the sources. Keep asking questions, keep demanding answers, and we'll see you next time.